Hello, everyone, and welcome to week 5. We're looking at violence, personality disorders, and forensics. Your assignments this week are Toussaint and Fitzpatrick, chapters 17, 18, and 22, Bolin, chapter 19, and your DSM-5 on personality disorders. There's a nice video I posted for you on my son was a Columbine shooter. It's actually a pretty good TED Talk. It's not very long. You'll have a domestic violence training that you'll be doing, and there's also a discussion board. Before we move into the rest of the information, I want to talk about transference and counter-transference. If you haven't already, are going to encounter this. You've probably encountered this and maybe didn't know what it was. In your work, maybe even as an RN. So typically, it's associated with a therapist, but it can have a role as a PMHMP, it can have a role in whatever work you're doing when you're caring for others. Very important to have a comprehensive understanding of transference and countertransference. Probably see this on a test and even your boards. So let's talk about it real briefly. Transference is a phenomenon in which the patient projects their feelings and attitudes onto the therapist, or in this case, the PMHMP, that were originally held for a significant other in the patient's life. And then countertransference is when the therapist, or the PMHMP, has a reaction to the patient that's based on their own feelings and thoughts and experiences. And trust me, this will happen. You will encounter a patient that you uh, just, I don't know, for some reason you feel for them. You're more empathetic towards them. Uh, you have to be careful and mindful of that and keep that in check. And then there'll also be patients that will trigger you and cause you to want to react in a certain way. But as a PMHMP, you have to always maintain that professionalism, always be reserved and not let certain personalities or traits trigger you or cause you to have that even a negative countertransference reaction when based on your feelings and thoughts about other situations. Okay, so we're going to look at personality disorders. There's different clusters. You need to know these. That's all I can say about that is you'll have to learn these, commit them to memory. You'll see these again and again. Cluster A, paranoid, schizoid, and schizotypal. Those are their odd or eccentric personality disorders. Cluster B, your antisocial, your borderline, histrionic, narcissistic, dramatic, emotional, erratic type of personalities. And cluster C is your avoidant, dependent, and obsessive compulsive. They're anxious and fearful. So, a little bit about cluster A personalities. You have paranoid. They're paranoia without signs and symptoms of a thought disorder. Um, So they may always be feeling like people are watching them, someone's out to get them, but they don't have a thought disorder. They don't look out their window and see the police driving by or the FBI is out there all the time. Schizoid, they tend to be socially detached, without again signs and symptoms of a thought disorder or autism spectrum disorder. And schizotypal, they're odd, peculiar behavior, paranoid a little, social detachment, often premorbid to schizophrenia. This is a picture of Ted Bundy here. He was a serial killer. You guys are probably familiar with that in the 70s. Um, Looking at antisocial personality disorder, he definitely had that, and probably also narcissistic personality disorder. So, antisocial, blatant disregard for others, and they have to have three or more of the following: um, failure to conform to social norms, deceitful, lying, conning others, impulsive, irritable, aggressive, consistent irresponsibility, lack of remorse. Occurring since the age of 15. However, the diagnosis is given after the age of 18, and then evidence of a conduct disorder as well. Borderline personality disorder, you will encounter this. It's a disorder of relationships. They have a lack of sense of self, and they have five or more of the following: frantic efforts to avoid abandonment, patterns of extremes in relationships, love, hate, love, hate. It's very extreme, back and forth all the time. Impulsive, self destructive behaviors, recurrent suicidal ideation or self injurious behaviors, affective instability, and extreme emotions. And I mean extreme. Chronic emptiness and transient paranoia or disassociation. Typically, they have higher rates also of trauma, childhood trauma in their lives. And some nice clinical nuggets for you. Remember, nobody wants to have borderline personality disorder, and people with borderline personality disorder deserve an accurate diagnosis. And I think it's, sometimes we're afraid to tell patients that they have borderline personality disorder, but if we can accurately diagnose it and let them know and get them into treatment, dialectical behavioral therapy is a best form of treatment for that. Then it is possible to have remission and have an improved life. And then remember having unconditional positive regard and instilling hope in these patients. The prevalence, 1.6% of population, though this number may be as high as 5.9. 75% diagnosed are women, i.e., 1 in 4 are men. And it can coexist with PTSD, major depressive disorder, bipolar disorder, but be mindful of an accurate diagnosis. Histrionic personality disorder. They have to have five or more. And remember, be careful that you're not treating borderline or you don't get that confused with borderline personality disorder. So, for histrionic personality disorder, they can be uncomfortable, if not the center of attention, inappropriately seductive or provocative, rapidly shifting shallow emotions, use physical appearance to draw attention to self. Their speech is impressionistic and lacking in detail. They are theatrical and exaggerated with emotions and expression, and consider relationships to be more intimate than they actually are. And it's easy to confuse this again with borderline, so be careful with that. Narcissistic personality disorder, again another cluster B, pervasive patterns of grandiosity, need for admiration, lack of empathy, and five or more of the following: grandiose sense of self-importance, preoccupied with power and success. He or she is special, unique, only associates with others of high stature. They're entitled, exploit others, they're envious of others, and arrogant. A difficult personality to work with, by the way. Cluster C personality, you have your avoidant personality. They fear criticism. They feel inadequate. They avoid situations that make oneself vulnerable. I actually believe I have a patient with this right now, um, who's really struggling with some things. So yeah, uh, interesting personality disorder there. Dependent personality, they have difficulty functioning without the support of others. That can look a little bit like borderline, right? But more of a dependent personality. Obsessive compulsive, they're preoccupied with maintaining order, perfectionistic, they hoard money or objects. Um, and it's distinctly separate from OCD, where there are true obsessions. So be mindful of that. Don't get the two confused. Some questions to think about. Uh, how do you feel about working with someone who has a history of criminal behavior? I can tell you that a lot of my clients do. They've been in prison, they've been in jail, they've been in trouble in some way. So think about how you feel about that. And how does a person with borderline personality disorder make you feel? Um, you want to be prepared for that, by the way, if you encounter that or when you encounter that. And then, can someone have a borderline, a bipolar disorder, and a personality disorder. I think we touched on that a little bit. So, in summary, personality disorders are common, and we need to be mindful of transference and countertransference, and then treat the symptoms, validate the discomfort. Remember unconditional positive regard. And people with personality disorders deserve an accurate diagnosis and treatment. So, we're going to look at self directed violence, suicide, and self injury behavior. So, non suicidal self injurious behavior, or NSSIB, or SIB, self injurious behaviors, cutting, burning, head banging, swallowing objects. One thing I didn't put in here now is they're embedding objects under the skin, such as paper clips or sharp objects. So there's embedding as well that's going on. And why do people cut? Well, I've asked patients, and I've done some research here too, but physical pain is greater to help them deal with the psychological pain. They have often told me to because they want to feel something, they want to escape the pain that they're feeling. It's a cry for help, and as I say here, to feel something. Some of them do it to punish self. Uh, some of them feel they're so unworthy or that's what they deserve. And again, it's generally a form of escapism, disassociation. Some interventions normalize but don't sensationalize what's going on. If you happen to see a patient with multiple scars on their arms, you can just simply ask them, do you cut? What's going on there? You don't want to sensationalize it. Avoid power struggles. Treat the symptoms. Listen. Be therapeutic. Dialectical behavioral therapy can be very helpful for for these people. And again, looking at suicide risk factors, demographics, gender, race, marital status. We know that men, white men in particular, unmarried white men, have higher rates of suicide. Uh, and then your diagnosis, looking at that behavior, are they impulsive? Do they have severe anxiety? Trauma. We know trauma is a big cause for some of these um, disorders and behaviors. Substance use decreases and lowers the impulses, right? So, um, family history, kind of a cluster effect in teens. Teens will often do this stuff together. I recently had a teen who was cutting, and she shared with me that her friends were doing the same thing. I was quite alarmed. Some questions to think about. Do risk factors mean anything? Well, yes, we know they do. Um, if someone is going to kill themselves, how can we really stop them? Think about that. And then, if self-injury is self-injurious behavior always non-suicidal? So, assessing suicide risk, you guys have done that CSSRS training. I hope you found that helpful. Ask and listen. At every visit, I'm always asking if they're suicidal, homicidal. You always want to ask that. And what they say versus what they mean? For instance, I'm suicidal. So is there a plan, a means, an intent? Are they future oriented or not? What's their affect? I frequently will have patients tell me, well, I'm not suicidal, but if I died, I wouldn't care or it wouldn't matter to me. That's sometimes how depressed they feel. But they say, I have no plan to kill myself. I don't want to kill myself. But if it happened, that would be okay. And that's sad to hear. Sometimes you have to consider hospitalization. Are they an explicit and life-threatening danger to self or others? So non-suicidal self-interest behavior typically does not qualify, and in fact, hospitalization may perpetuate institutional dependence on one's need for safety. Uh, and then at what point along the suicide self-harm spectrum should hospitalization be considered? So hospitalization is a last resort. It's appropriate when outpatient efforts have failed or would be detrimental to the safety or well-being of the individual. Some pharmaceutical options, clozapine, FDA approved. It's difficult to manage, though, as we said, and may not necessarily be appropriate for major depressive disorder. Seroquel and other second generation antipsychotics have some mixed evidence. Um, Lithium, up to five-fold decrease in suicide attempts. Risky again in overdose, challenging to manage. And then antidepressants, remember they have a black box warning for suicide, and there's a delayed onset of action. More pharmaco considerations. I'm sorry, it's more pharmaceutical considerations. You want to treat the symptoms such as sleep or anxiety. Consider co-occurring substance use. Always consider co-occurring substance use. And then naltrexone for self-interest behavior. That has been shown recently to be helpful in that. There's some other studies that are kind of promising looking at the use of naltrexone for self-interest behavior. Let's spend a little bit about the violence directed towards others. Mm. Some myth busters here. So, despite the fact that most people with serious mental illness are never violent, and 95 to 97% of gun violence is not caused by mental illness, a 2013 Gallup poll indicated that 48% of Americans blame the mental health system a great deal for mass shootings in the U.S. When there is an incidence of mass gun violence, mental illness is routinely discussed as a likely cause, and the rights and liberties of up to 25% of Americans with mental health conditions are placed in jeopardy. It's pretty sad when you consider that. So some types of violence, you have intimate partner violence. You'll be doing a training on that this week. Some child abuse, elder abuse, sexual assault, human trafficking, bullying, and then violence directed towards healthcare providers. So intimate partner violence and child elder abuse. And let's look at the cultural impact. Tends to have a blame the victim mentality, right? It's their fault. They got what they deserved. That's unfortunate thinking. Tends to be male dominance, although women can abuse as well, but not as dominant. Poverty, cultural norms around reproductive rights and other issues, and cultural norms about discipline are also something that we need to think about, but does not excuse behavior, abusive behavior, I should say. Human trafficking. Hopefully, all of you have done or will do training on human trafficking. It's a huge problem and how to recognize that. I recently worked in inpatient and took care of a young man who was living in a drug house. He's 19, and I believe he was probably being trafficked for sex and drugs. He does not seem to think so, but he also had um, a learning disability and other things, which to me, when I assessed him, would indicate that he was likely being trafficked. So, may or not be for sex, may also be for service um, and slavery. So remember that. Runaways are particularly at risk. Children, adolescents, immigrants, most at risk. Risk of STDs, HIV, other infections, poor health, malnourishment, substance use. Big problem with that. Bullying. I'm sure all of you recently heard of the beautiful young girl in New Jersey who killed herself. She was being bullied in high school. So tragic what happened there. So peer victimization includes verbal harassment, physical assault, rumors, exclusion, behaviors may occur in person, in writing, or in social media. And many schools, thank God, have adopted zero tolerance for bullying. And remember our ACEs and what ACEs have to do with all of this. So let's look at violence towards healthcare professionals. There's physical assaults, threats, inappropriate sexual comments, stalking, false accusations, frivolous lawsuits, unsubstantiated complaints to legal boards, licensing boards, abusive phone calls, vandalism, trespassing, loitering, displaying knowledge of a clinician's personal life. So this happens to all of us, um, and I would say it should not be tolerated. But if people with mental illness aren't violent, then who's threatening us? Something to think about. So some safety measures you should take. Office arrangements. You want your desk or your chair closest to the door. Having a safety alert system. Having some social media safety. Care in displaying personal photos in your office. I don't have any personal photos in my office at all. Having an office buddy, very important. Zero tolerance for non-supportive environments. If you work at a place where they aren't supportive of violence, I would leave. That's what I would do. Um, and then you have to, if you need to, involve legal authorities. So if you're ever threatened or hit, and police need to be involved immediately. No tolerance for that whatsoever. I have zero tolerance for it, and you should too. So, why are people violent in the healthcare setting? Well, often, this is a big one, illicit drugs or alcohol, pharmaceuticals, an illness or an injury, trauma, they feel threatened. They could be having internal stimuli like delusions, or something else going on, conduct disorder, a low IQ, or a head injury. So, how do we assess for violence? Well, you have your Borset violence checklist. That's why they're inpatient. And there's a V10 risk assessment. Intuition. So, are they pacing? Are they seem dissatisfied with care? Are they mumbling to self, name calling, yelling? You can see when people start to escalate and get more aggravated. So, tune into that. Be mindful of that. Uh, Hopefully, you will all take or get a class on de-escalation when you're out working or wherever you're at. A very important course to have. Some questions to ponder. How do you maintain safety in a trauma-sensitive environment? All right. And should seclusions and or restraints still be used for violent patients? What do you think about that? They are still used. Um, I have had to put patients in seclusion. I don't like to use restraints, but I have had to put them in seclusion and let them know once their behavior improves that they can come out. Um, but oftentimes they may not be safe to themselves or somebody else or the staff. So treating violence, when is hospitalization appropriate? Well, when there's a clear and explicit danger to self and or others. When is seclusion or restraint indicated? Well, again, when there's clear, explicit, and imminent danger to self and or others, and not for property damage. That's not a reason to restrain someone, or when they're verbally agitated. But again, they have to be a danger to self or others. Restrictive approaches such as involuntary hospitalization um, and restraint should only be used when lesser restrictive options have failed or cannot be used to immediately restore safety. And some medications to treat violent individuals. Remember that the use of uh, chemical restraints, you have to be very careful with that. And a chemical restraint is the use of a medication to induce sedation. Uh, that is not what the primary purpose for that medication is for. So patients or guardians must still give consent unless allowed to force medications per state law, or maybe they're inpatient and they might have standing orders for that. Benzodiazepine, typically Ativan, lorazepam is most typically used. You have anticholinergics such as Benadryl or benztropine, typically given to avoid EPS. And you have your antipsychotics like Haldol, ziprasidone, Geodon, or olanzapine, Zyprexa. And be careful because you can cause a drop in blood pressure when olanzapine and lorazepam are used simultaneously, and you can also cause respiratory depression. So you want to be careful with this. and the use of these, but you may need to use them. I'm not saying there's not a place for them. This is very important to know, Tassaroff principle. It's based on the 1976 ruling of Tassaroff versus Regents of the University of California, and it occurred after a person with paranoid schizophrenia, Mr. Podar, disclosed a plan to his psychiatrist to murder a female love interest, Mrs. Tassaroff. And the psychiatrist did not disclose this to anyone else. And Mr. Podler did indeed kill her, and her family sued and won, setting a landmark legal standard of duty to warn. So it is your duty. If you ever have a patient telling you they want to hurt or kill someone, you need to notify them right away, find them, and notify the police. All right? You have a duty to protect. Um, so uh, remember, the degree of risk may be legally defined in each state. You want to err on the side of safety, but be mindful of HIPAA, and do not excuse. And it does not excuse a clinician from legal liability to care for their perpetrator. So you have to sometimes continue in care with these patients. I'll look a little bit at forensic psychiatry. So the PMH care in the context of the legal system is someone competent to stand trial. You may have to do an evaluation. Um, I would recommend getting some additional training and with your current wherever you live and looking into that and what their guidelines are for that. Determining of competency for self-management and caring for persons in jails and prisons, and court-mandated treatment. I've had several patients who have been court-mandated, and if you work in a community mental health setting, you will likely have many patients who are court-mandated to receive treatment. And then the extent of the role of the PMH APRN may depend on the state and the ability to practice independently. So, in summary, people with mental illness are more likely to hurt themselves than to hurt others. But be careful because they can still, some of them, be violent. Consider the role of trauma in assessing persons as a victim or a perpetrator of violence. The cause of violence may not be mental illness. Just be very mindful of that. And then stay safe and have zero tolerance for any type of violence, whether it's verbal, physical, um, mental, just zero tolerance for that. And that's it. We're done for this week. So next week we're looking at ADHD and eating disorders. Here are your readings here. And you'll have a short little video on marginalized voices. It's about eating disorders. And then there's a quiz. All right. I wish you guys the best. Take care.